I thought today I would talk about the toxicities associated with tenofovir, at least the formulation of tenofovir that's most widely used in the region, TDF. This came up during last week's case presentation, and given how many individuals in the region are on this medication, I thought it would be useful to review some of this. I have no relevant disclosures. Hopefully by the end of this, you will be able to describe incidence and pathophysiology of tenofovir-induced renal toxicity, describe the association between tenofovir and bone mineralization disorders, and discuss the implications of these toxicities for the clinical management of HIV-infected persons. So tenofovir has its impact on the kidney at the area of the proximal tubule. This is a diagram of the nephron, the key working unit of the kidney. What tenofovir can do in certain individuals is cause the proximal tubular cells to malfunction. And the proximal tubular cells are important for resorbing quite a few compounds from the urine back into the bloodstream, specifically certain small proteins, glucose, phosphate, uric acid, vitamin D. And any disruption of the function of those cells can result in spilling of those compounds into the urine at inappropriate levels. Severe dysfunction can actually lead to death of these cells in the proximal tubule, acute tubular necrosis, even interstitial scarring. We've actually been able to work out the very likely pathophysiology of what's going on here. This is a schematic of cells in the proximal tubule. At top, panel A shows a normal physiology. Tenofovir, shown as the little blue TF circles, is imported into the cell and then ideally should be promptly cleared by proteins called MRP2 and MRP4. Unfortunately, as shown in panel B, in some individuals, for various reasons, that tenofovir doesn't get cleared efficiently and it builds up. And unfortunately, tenofovir, like many other drugs in its class, has a cross affinity for a key enzyme in the mitochondria called DNA polymerase gamma. And so when you get enough tenofovir in these cells, it starts to bind to that key enzyme in the mitochondria, and the mitochondria stop working. And the mitochondria, of course, are the key energy producing unit for the cell. Without functioning mitochondria, the cell starts to develop some very severe problems in performing its essential function. And you can even see with electron microscopy the distortions in the mitochondria within these cells when they get poisoned in this manner. On the left, you see a normal mitochondria, and on the right, you see one that's been essentially poisoned by this process. The cristae are disorganized. There are these bizarre inclusion bodies. So you can actually see this on a kidney biopsy in patients who have this toxicity. How big a problem is it? Well, we didn't see this very often in initial clinical trials, but you have to remember that clinical trials typically enroll pretty healthy patients. I think better information comes from these longer-term longitudinal observational studies. This comes from one such study involving over 10,000 patients in the Veterans Administration Service in the United States. And what they found was that every year of using tenofovir was associated with about a 1/3 increase in the risk of developing proteinuria, about a 1/3 increase in the risk of developing chronic kidney disease, and about an 11% increase in the risk of developing sort of rapid kidney renal dysfunction. Other risk factors for this kidney toxicity include the usual sort of risk factors for kidney disease: hypertension, diabetes, older age, lower body mass, established kidney disease. Also, interestingly, ritonavir, probably because it inhibits one of those transport proteins, as well as there's a certain genetic predisposition. One of the genes that codes for one of these transport proteins in the kidney, if that gene has a mutation in it, then the transporter will not function as efficiently, and that can lead to an intracellular accumulation of the tenofovir. So in terms of the, sort of epidemiology and how widespread this is, again, it kind of depends on whether you look at the initial randomized trials versus the observational studies. Observational studies typically showing this to be a bit more serious problem. In a large cross-sectional study of about 3,000 patients, found that nearly 6% of patients developed a drop in their creatinine clearance below 60 mils per minute after 4 years of exposure to a regimen that included tenofovir and a ritonavir-boosted protease inhibitor. And then again, that larger study in the VA involved over 10,000 patients. And notably in that study, the kidney function typically did not recover after the tenofovir was stopped. And we've seen conflicting reports about whether stopping the tenofovir will lead to resolution of the problem or not. It probably can if it's caught early enough, but if you get tubular necrosis and interstitial scarring, then the impact may be permanent. Now, tenofovir has also been associated with bone toxicity. The pathophysiology of that has not been worked out as clearly, but the kidney is intimately involved in bone metabolism, and there are certain hormones and compounds that are involved in bone metabolism, such as calcitriol, vitamin D, phosphate, parathyroid hormone. So anytime you start to cause kidney dysfunction, you run the risk of disrupting normal bone metabolism. And it's probably through one of those mechanisms that we're seeing the impact on bones. These are data from a randomized controlled study that was really looking at the efficacy of two different nucleotide backbones, either tenofovir combined with FTC versus abacavir combined with 3TC. But helpfully, they performed a sub-study to look at bone mineral density in these patients. And what you see in the left-hand box, patients randomized to receive tenofovir are shown in the sort of light purple, had a significantly more drop in their bone mineral density as compared with patients who received abacavir instead. So there's definitely an impact on bone mineral density. This has been seen in other studies as well. Just how clinically significant is it? Well, most studies have not identified increased risk of fracture, but this one did, and this was a pretty large study also coming out of the VA involving over 50,000 patients that were tracked during the HART era. And they found that any use of tenofovir was associated with a significantly increased risk of developing an osteoporotic fracture. So the bone mineral density effects are probably real and deserve to be thought about. So implications of clinical management. I would say you need to avoid tenofovir if at all possible in patients who already have significant pre-existing renal or bone disease. Patients who are on tenofovir should be monitored for renal dysfunction, ideally like a renal panel every 3 to 6 months, and also a urinalysis every 6 months, because again, often the problem starts with spilling of glucose, phosphate, and protein. It's important to minimize the other potential risk factors for renal dysfunction or bone demineralization. and actually consider screening for osteoporosis in patients who have other risk factors and are on tenofovir. If a patient on tenofovir develops a decline in renal function or develops osteopenia or osteoporosis, it's worth looking at stopping the tenofovir if at all possible. Again, if caught early enough, this may have a significant beneficial impact for the patient, because switch studies have shown improvement for many patients, either in renal function or in bone mineral density after the tenofovir is discontinued. Now, last week I alluded to a newer version of tenofovir that's come out, tenofovir alafenamide. We abbreviate that as TAF or TAF. This compound appears to lack the renal and bone toxicities that tenofovir has. And that's primarily because administration of TAF results in much, much lower, about 90% less circulating levels of tenofovir in the plasma as compared with tenofovir disoproxil fumarate, or TDF. And that's owing to the fact that it's much more efficiently carried in the plasma and into the target cells. So you simply have much, much less of it around, much less of it getting into the kidneys, and therefore we've seen far less toxicity with that. So just to wrap up with conclusions, tenofovir has been clearly associated with a renal proximal tubule pathology that results in elevated risk of proteinuria, acute kidney injury, and chronic kidney disease. It's also been associated with decreases in bone mineralization and even an increased risk of osteoporotic fractures in one study. So implications for clinical management include avoiding tenofovir where possible in patients with pre-existing renal or bone disease, minimizing additional risk factors for renal or bone disease, regular monitoring of renal function in persons on tenofovir, and consider osteoporosis or bone mineral density screening in these individuals as well, and discontinue tenofovir wherever possible in patients who develop renal or bone toxicity that is either severe enough or that could be attributable to the tenofovir. So I'll go ahead and stop there and open it up to questions and comments.